Thank you. Well, thank you to everyone for joining us today for MVC's Health and Action Work Group. My name is Emily Bear, and I am a Senior Site Engagement Coordinator here with MVC, and it is my pleasure to be facilitating this work group for you today. Our agenda for today's work group will be to briefly review some housekeeping and P4P credit reminders. Then we will hear from a presentation from one of our members, Maryam, on advancing care and improving outcomes for patients with ICH. We'll then lead into a discussion and Q&A portion of the meeting, and then close out with some upcoming MVC events and updates. So before I introduce our presenter, just wanted to review a few housekeeping items. First, this workgroup session is being recorded, and we will provide you with the slides and the recording following the workgroup. We always provide that via a follow-up email. Just give me a little bit of time to pull all those resources together before the end of the day. Second, a reminder to please double check that your mic is muted throughout the presentation so that we can get the best recording of Maryam's presentation as possible. And then finally, we'll be monitoring the chat throughout the presentation to collect any questions that come in, but we will hold questions until the end of the presentation and facilitate that question and answer and discussion portion. For those of you attending this work group for P4P credit, we look forward to your active participation throughout the work group. Today, that's going to include just asking questions and being part of the discussion. We will also be sharing a post-work group survey at the end of today's work group. That link will be provided in the chat. It will also be provided in the post-work group email. For hospitals participating in P4P who would like to receive credit for your attendance to this work group, that survey completion is mandatory. As a reminder, please note within that survey the hospital that you're attending this work group on behalf of, so we can appropriately allocate credit for your attendance. All right, so without much further ado, I want to introduce today's speaker. Maryam Hakemi-King is a board-certified adult gerontological nurse practitioner. She earned both her Master's of Science and Master of Science and Bachelor of Science in Nursing degrees from Oakland University. As a nurse practitioner, she's worked in a variety of care settings, including subacute rehab, family medicine, and the CDC. Prior to earning her graduate degree, she worked as a trauma ICU nurse at Genesis Hospital in Grand Blanc. She currently manages the stroke program for the DMC downtown campus, which includes both a primary stroke center and a comprehensive stroke center. And she's also served as a stroke reviewer for the Joint Commission for 6 years. Maryam is passionate about improving care for patients with hemorrhagic stroke and is currently working with the American Heart Association on a 2-year national initiative aimed at enhancing hemorrhagic stroke care. And that is what she is here today to speak to us all about. So join me in welcoming Maryam. I'm going to transition to her presentation.
All
Maryam, just
right,
let me know when you want me to progress slides.
sure. Thank you so much for that introduction. And just to be respectful of everyone's time, I'll just kind of get right into it. So as mentioned, I will be discussing the American Heart Association's ICH initiative, Detroit Receiving Hospital's participation in this project, and some of the process improvement projects that we have initiated at our hospital as a result of being part of this collaborative group. Next slide. So topics for today, I will begin by reviewing some key facts about ICH strokes, then get into details about this ICH initiative with American Heart Association. I will also provide a brief overview of our stroke program at Detroit Receiving Hospital, review the ICH projects that we are working on, and then I will conclude by discussing the ongoing research that is part of this initiative at our hospital. Next slide. So some ICH stroke facts, hemorrhagic strokes account for approximately 13% of all strokes. Despite being less common, hemorrhagic strokes are responsible for more than 40% of stroke-related deaths. ICH is associated with a high early mortality rate of 30 to 40%. And recent nationwide studies have shown that there is an increase in ICH incidence among young and middle-aged adults. And there has been significant amount of improvement in the care of and research in care of ischemic stroke patients over the years. However, similar progress has been kind of lagging behind when it comes to care of ICH patients. Next slide. So as a result, AHA initiated a 2-year project to improve ICH care in US. They have selected 15 sites in the nation as a collaborative team to participate in this project. The aim of this initiative is to create a national model of effective ICH care, including using minimally invasive perivascular surgery, or as we call it, MIPS. MIPS is a minimally invasive procedure that uses a tubular retractor to navigate through brain's natural folds alongside an instrument designed to remove clots and prevent damage to brain tissue. AHA is using data from all of these sites, from ICH metrics through Get With the Guidelines, data from implementation of ICH process improvement initiatives throughout these sites, and like the outcomes of those initiatives. Feedback and findings from all the collaborative discussions that we have, data from identification of successful models of care through process mapping, and then it's translating all of this information and data to create this report that can be utilized by hospitals in the nation that want to improve ICH care in their facilities. Next slide. This is a map of all the 15 sites in the US that are participating in this collaborative project. And just to expand on the last slide, some of the areas that we are focusing on as this collaborative working group together includes ICH patient triage process, patient selection criteria for MIPS procedures, surgical timing, post-op care, staff training and education, and then outcomes. We discuss and review strengths, barriers to care, and then all the opportunities that we identify in all of these domains. Next slide. So I just want to kind of provide a brief overview of our stroke program at Detroit Receiving Hospital. So we are a comprehensive stroke center. We do see a lot of ICH or hemorrhagic strokes, and we actually had a 43% increase in our ICH admission cases from 2023 to 2025. Some of the unique features of our program, our neuro ICU has 24/7 coverage by neurointensivist. And actually, 5 out of 7 of our stroke attendings are neurointensivists in training. So it's kind of nice to get that level of knowledge for every stroke code right from emergency department. We do have a very collaborative culture between emergency department, neurology, neuro ICU, and neurosurgery. Our emergency department director, he is an active member of our stroke team and participates in any type of stroke initiative that we want to implement at our hospital. We do have a very clear stroke activation workflow with dedicated stroke pager. We have a designated stroke holding area in our PACU that is right between our emergency department and neuro IR, and it's kind of sandwiched in between these two departments. And it's very nice for transfer patients that we get. We have a selection criteria for minimally invasive brain interventions, and we offer these procedures 24/7. We have trained neurosurgeons that are on call 24/7. We use AI technology for identifying ICH, and we have very structured documentation framework for ICH consults, code ICH, which I will get into. We do quality audits, and then we have a monthly case review, stroke case review meeting. Next slide. So I will kind of get into all the ICH initiatives that we have implemented at Detroit Receiving Hospital as being part of this collaborative group with AHA. Next slide. So we have implemented specific ICH quality metrics and measures that I will discuss a bit more on the next slide. We are now conducting a more in-depth analysis of post-neurosurgery outcomes and care, including for our MIPS cases, looking at duration of NICU stay, and then level of functioning at discharge, and then following up in 90 days. We have, like I said before, implemented a very structured template for ICH consult note for our neurosurgery team and neuro ICU that they have to follow. We have implemented a code ICH protocol that is kind of like code stroke, but more specific to ICH patients, and I will discuss that a little bit more on the next slide. And this is actually part of this research project that we are conducting at Detroit Receiving, and we just have submitted our abstract to American Heart Association for the 2027 International Stroke Conference. Next slide. So getting into some of the metrics and measures related to ICH care, we are looking at door-to imaging for these patients under 25 minutes, door-to anticoagulant reversal agents under 60 minutes, door-to first blood pressure medication administration under 60 minutes, and door-to blood pressure goal under 120 minutes. So the 2022 American Heart Association ICH guideline had huge emphasis on blood pressure management for ICH patients, timely blood pressure management for ICH patients. So it is very important for us to get these patients' blood pressure to a set goal very quickly in their acute phase. We do require our neuro ICU team to document an ICH severity score under 6 hours or prior to any intervention. And then we also focus on blood pressure range prior to discharge. So we want, for ICH patients, we want their systolic blood pressure to be less than 130 for at least 24 hours prior to discharge. Next slide. So some of the process improvement initiatives that are in place. We are tracking our door-to neuro ICU bedtime for all of our ICH patients. And we are focusing on ICH presenting symptoms. And this is kind of huge also with our collaborative AHA group, because a lot of these ICH patients come in and they don't have your textbook stroke symptoms initially, like unilateral weakness or facial droop. So they don't qualify for your stroke activation protocol. And so by gathering this data on how these patients are presenting, we are hoping that we can find some common denominators in these patients with their presenting symptoms so that we can gather that data and hopefully incorporate it in our stroke code activation. Early therapy, we know that this is important for all stroke patients, but for ICH patients, we do want all of the services, so PT, OT, and speech, all of them to see the patient within the initial 24 hours, and we track their performance individually, and we report that in our stroke committee meeting every month. And then every ICH case gets now a pre-morbid modified ranking score, a modified ranking score at discharge, and then a modified ranking score at 90 days. And that way we can further analyze outcomes for all of our interventions. So my last slide here, um, I do want to kind of briefly talk about our code ICH process. I can't get into this into a lot of details because this is part of our ongoing research. And as I said, we have just recently submitted our abstract to American Heart Association for the 2027 International Stroke Conference. But modeled after your traditional code stroke, code ICH is activated immediately upon identification of bleed on imaging. Primary goals are to facilitate coordinated multidisciplinary care, streamlining communication between all involved team members, reducing time to treatment, and expedite transfer to neuro ICU. To date, the results have been highly encouraging. We have seen reduced door time to treatment time, significant drop in our door to neuro ICU bedtime, and also we are seeing a lot of improvement in care coordination and efficiency. We are very excited and we are continuing to refine this process, evaluating its impact and exploring opportunities to further expand this research. Next slide. So just kind of getting into questions and my references. Right. Any questions?
Leave these references up here, but we'll also provide the slides, like you mentioned, in our follow-up email, so you can you know, resource some of these references that Miriam's provided. I've been checking the chat, Miriam. We haven't had a question come into the chat quite yet, but I know it takes sometimes folks a little bit to collect their thoughts. So if you want to unmute yourself and ask Miriam a question about this work, or if you'd like to pop something into the chat, you're welcome to. Give you a couple minutes here to think about that. Um, to kick things off, though, I was sort of curious, Miriam. Obviously, a lot of this work is happening on the inpatient side of things. I am curious if there has been any, thoughts about the sort of post-discharge aspect of this in terms of looking at follow-up care for these patients or readmission rates. Has there been any, post-discharge kind of metrics that you've been interested in or plan to look into?
Yeah, so one of the things that we are doing is the 90-day follow-up phone call. And so we do a modified ranking score at that time to get patients' level of functioning in 90 days.
Mm-hmm.
And so one of the things that we are doing, kind of looking at different interventions and looking to see if we can see any difference between for example, MIPS or crani or other procedures and see if there are any differences. So part of this research that we are doing, we're starting kind of like with the code ICH, and then the next step would be to like kind of incorporate following up on these patients and looking at their progress and outcomes and kind of incorporating that into the research. But as of now, we're just doing the 90-day follow-up phone call. We do
Gotcha.
have a neurology clinic or a stroke clinic. So all of our stroke patients get a follow-up at the clinic within 3 weeks of discharge. Part of that phone call when we call patients is to make sure that they do have an appointment at our neurology clinic and that they have already followed up or going to follow up with our neurology team.
Okay. Great. Thanks so much for that. Looks like we got a question come in. Um, what's the volume of patients with IC or the volume of ICH patients that you're seeing on a daily, monthly basis? And do you have any idea of what their demographics are generally? sort of suggesting.
Yeah, I don't have the volume, right now that I could just give you a specific number, but I can tell you that last year we were kind of like analyzing our volume and our data, and actually we had seen, compared to other hospitals in Detroit, we had seen more ICH patients.
Mhm.
As far as demographics, we do see younger population.
Mhm.
I I would say that like anywhere between 30 to 50s, um, they tend to be younger. As far as male or female, it's pretty much 50%.
Okay. I'm going to skip one question and come back to it because I think this one kind of relates to what we were just talking about. Deanna was wondering if you include hemorrhagic conversions in this kind of cohort of patients that you're looking at.
No, these are all ICH patients that are presenting through our emergency department. We're not incorporating in-house strokes or hemorrhagic transformations at all. So just it's the focus is from um, kind of improving our process from emergency department to neuro ICU.
Great. Thank you. Okay, so then going back to Shelby had a question about sort of networking and collaboration. She wondered if you, DMC Detroit Receiving, would be open to networking with other locations, other stroke programs, and then if so, do you have a contact that folks could connect with? Or any material slides or materials outside of these, of course, that could be shared.
Yeah,
Out
so
to you.
our stroke medical director, Dr. Mohammed, he is actually very open to working with other hospitals and sharing our practices. Um, I can kind of provide my email. I mean, you have my email and my phone number, so you can share that with the team, and I would be happy to set up a meeting, kind of discuss our projects further with any hospital that is interested.
Great. Miriam, if it's okay with you, I'll include your email in our follow-up email, and as well as a CC, so folks can get in touch with you that way.
Yes, for
If
sure.
they'd like to learn more. Great. Okay. Jill was wondering, what's been most effective for getting frontline nurses and physicians engaged when you're seeing, this performance needing to improve in this particular line
Yeah,
of inquiry?
I really think, I think over the years, we have been able to kind of establish a very collaborative partnership with our emergency department. And as your emergency department is kind of like your gateway to your stroke program. With having that support from our emergency department director and getting him involved in everything that we want to do, just kind of getting his support, it's been very helpful to implement anything in our hospital. For example, when we started this code ICH process, our emergency department director was actually responsible for educating our entire emergency department physicians and providers and nursing manager and the nursing staff even. And he is kind of following up on all the fallouts. We communicate on weekly and monthly basis about this project, and just kind of getting your emergency department support goes a long way.
Mhm. Thanks so much for that. I know we hear fairly consistently, for interventions in terms of engaging, frontline workers, that really having that leadership seems to be very important. Okay. Alex notes that most of the hospitals that they work with are smaller. and would be sending versus receiving or managing these particular stroke patients. She's curious as to which metrics you think are most important to focus on, or what opportunities might you foresee for patients you receive from smaller sites.
So if you're talking about hospitals that are transferring to us, smaller hospitals, I would say number one would be blood pressure management for these patients. I mean, that research has shown that when you get the blood pressure for ICH patients into a target goal of 130 to 150 systolic, that they do have better outcomes. So I would say starting blood pressure management early on, if you have means of doing anticoagulant reversal, starting that process prior to transferring the patient, I think those are the two most important things.
Alex, I saw you turn
Thank
your
you.
video on.
I
Did
just
you
want
have
to
a
say thank
follow-up?
you. Yes.
Yeah. Yeah, and I would be happy to, I don't know which hospital you're from, but if you want to reach out, we can like discuss even more if you have further questions.
Yeah, I would love to. Thank
Yeah. Yeah.
All right, great. Deanna had a follow-up question about you mentioned that we're seeing younger patients with ICH. So she's curious if you had a pediatric protocol, specifically for this population.
So we have Children's Hospital next door. We don't get pediatric patients. They have their own protocols. I think the youngest patient that I have had was 18. But we do follow the same protocol as our adults for those patients when they come in. Yeah.
Gotcha. Christy is curious, what strategies have you used to ensure compliance with timed metrics or meeting timed goals? I know a lot of the interventions that you've had are meeting certain timed out protocols. So curious if there's specific strategies there you found useful.
Yeah, so pretty much every stroke case, especially ICH cases, so every case gets audited post code ICH activation and then throughout patient stay. And then all the fallouts, depending on what they are, they either go to our monthly case review meeting. And in our monthly case review meeting, we have representation from neurology, neurosurgery, emergency department, quality. So it either goes there for further discussion and analysis, or it goes to emergency department, director, or nursing. We may have to provide like team education or individual education, and then we report on all of our performance, how well we are doing with all of these metrics, kind of track them over time, monthly, yearly, year to year, and we report on all of that in our stroke committee meeting so everybody's aware. I
Great.
hope I answered your question.
Sounds like that answered it. Last question that I've got in the chat right now. Charles notes that in their area, they struggle a lot with patient compliance. So curious if you face any struggles with patient compliance within your cohort as well.
Yeah, I would say patient compliance number one issue for us, for our patient population, would be compliance with their blood pressure medication. I think the highest blood pressure that I had this year was a 287 over 109. So our patients, their number one risk factor for both ICH and ischemic stroke is hypertension. We see a lot of that in Detroit. And so that is part of your community outreach and education, you know. And then we do have a very unique population that comes in Detroit. We do get a lot of patients that initially present and we have no clue about their history. They're found down in like at the casino or at a bar. We have a homeless population. Um, but as far as compliance, I would say number one issue is hypertension. And then just to kind of tie that into like patient follow-up, as we were discussing earlier, a lot of times it's hard to reach these patients after their discharge to make sure that they are taking, you know, their medications as prescribed, that they did do their follow-up at the neurology clinic. We don't have a phone number for them. So those are some of the challenges that we face. But yeah, I would say hypertension and is number one issue for us.
Yeah, makes sense. All right. We've got a couple other questions that are coming in here. What's the average length of stay for an ICH patient?
Um, Anywhere from depending on the severity, anywhere from 3 days to 14 days. 10 days seems to be our average length of stay for ICH in the ICU.
Gotcha. Um, there's also a question about whether or not health literacy is a concern within this population, and then if so, how do you manage that?
Yeah, definitely it is. We do try to match our patients with a lot of community resources. Uh, we work with Wayne State University, and they have this great book of all the resources that are available in Detroit and are in our community that we try to match patients with those resources. I don't know if anybody on this call is familiar with CHAP program. There are social workers that do connect that we can refer patients to in the community, and they reach out to patient and address some of the concerns that we have with these patients. So there are different ways that you can utilize your community resources to help these patients.
Right. Do you know if CHAP is specific to Detroit, Metro Detroit?
Actually, they started in Flint,
Okay.
Michigan, and they're just expanding into Detroit, starting with stroke programs in Detroit.
Mhm.
It's very new to us, but it is, yeah, it's a nice program. And the nice thing about it is that you can get follow-up with
Mhm.
them after they do see the patient. So it's a nice program.
Yeah.
Yeah.
It was Christine brought up the WSU street medicine group, and I know there are several, street medicine groups spread out, to my
Yeah.
knowledge, within Southeast Michigan. I'm not sure outside of Southeast Michigan, but
Yes.
that might be another resource for, kind of doing some of this follow-up, and maintaining ties, with populations that we have a harder time connecting with. Great. Right. Any last minute questions for Miriam? Feel free to pop them into the chat, or unmute yourself. Give you a minute. Otherwise, we will close out the work group with just some reminders of upcoming events. Okay, we're getting lots of thank yous, Miriam.
All right. Well,
Thank you
thank
so
you so
much for
much too for this opportunity. So,
Thank you.
yeah.
It was lovely to hear about kind of a new topic for us.
Yeah.
All right. So we'll just close out with some brief reminders of the next few work groups being hosted by MVC. So we've got a sepsis work group coming up on Tuesday, September 15th. This will be a presentation from LeClaire Flint on their sepsis process. And then in October, we'll have a cardiac rehab work group on the 20th. MVC will be presenting at this work group a review of our new cardiac rehab focus push report, which is due to be released just prior to that work group. So if you are interested in cardiac rehab or sepsis, please join us for those work groups. And then with regards to other upcoming events, just a note here that MVC's Fall Collaborative Wide Meeting is coming up on October 9th. And we will be hosting a networking dinner the evening before on October 8th. Both of those opportunities have opportunities to network and connect with your peers, as well as a chance to earn P4P credit. Registration will be out soon for both of those events. So please keep an eye out for an email.
Emily,
Yep.
it actually just went out during the work group.
Oh,
So
great. All right, so check your inboxes for the registration for both the collaborative wide meeting and the dinner, Jesse.
no, just the
Just the
collaborative
collaborative
wide
wide.
meeting. Yep.
Great. All right, networking dinner to come soon then. All right. And then just a reminder as we're sort of thinking about attending collaborative wide meetings, MVC will host two additional collaborative wide meetings in 2027. So save the dates for those. Our spring meeting will be hosted on a Thursday this year. That's not a typo. May 6th at the Treetops Resort in Gaylord, Michigan. And the fall collaborative wide meeting will once again be in Livonia at Vista Tech on October 8th. All right, my last note here is that we are seeking presenters for our remaining 2026 collaborative work groups. We've just got a couple left that we're looking for presenters for. So if you are thinking that you'd like to present at an MVC event, be it a future work group or at one of our next collaborative wide meetings, you can submit a presentation proposal form using the link on this slide. I will also include it in the follow-up email. And we would love to hear from you about your presentation ideas. All right, it looks like Jesse just added the registration link into the chat. I'm going to add in the link for the post-work group survey. Okay, so feel free to grab that, and this concludes our work group for today. Thank you so much for joining us.